Thank you so much. So next slide, please. Okay. So the reason I chose to study disordered eating instead of eating disorders is because I wanted to encompass a larger sample of the population. As Indians, we often engage in very structured eating. As in India, eating is a very important part of the day. Therefore, it's a social interaction of sorts. Therefore, presenting very clear, very noticeable eating disorder symptoms is not possible for many. Therefore, by studying disordered eating, which does not always warrant diagnosis, I was able to cover a larger population. And I decided to study disordered eating in relation to internal dialogue because as part of the pandemic, as a result of the pandemic, not only have disordered eating symptoms increased, but so has conversations which we have with ourselves, or in general, our self-talk and internal dialogues. This is a method of compensating for the sudden lack of interactions we have with others due to lockdowns and quarantine, etc. So, inner voices, which is a part of internal dialogue, which can be basically described as our thoughts or any conversation we have with ourselves, are of three types: malevolent inner voices, benevolent inner voices, and omnipotent inner voices. Malevolent inner voices are those which are critical in nature. They are those which sort of make us feel bad about ourselves. They are associated with lower self-esteem in general. An example of a malevolent inner voice is, my voice is punishing me for something I have done. So in the context of disordered eating, this would be something along the lines of an individual's inner voice saying, you ate this item, this food item, therefore no one will love you. An example of a benevolent inner voice is, my voice wants to help me. Benevolent inner voices are those which are kind in nature. They are friendly in nature. They are nice to hear. On the other hand, omnipotent inner voices are those which are deemed to be very powerful. And that is how disordered eating in a way propagates itself. The disordered eating voices which those with eating disorders have, they are very powerful, that is omnipotent in nature. Self-talk is basically any conversation one has with themselves, just like inner voices. And self-talk is of 4 factors. It fulfills 4 factors: social assessment, it is critical in nature, it is reinforcing in nature, or it is with the aim of managing one's behavior. Social assessment self-talk is basically the self-talk using which we analyze our own social standing, social behaviors, or others' behaviors towards us. We analyze social self-talk in terms of, I want to analyze something that someone recently has said to me, or I want to analyze how I should behave in this situation. Critical self-talk is something similar to malevolent inner voices. It basically is that kind of self-talk which is harmful to one's self-esteem. So this sort of self-talk is activated when one ponders about something wrong they have done or something they could have done better. Reinforcing self-talk is basically something like benevolent inner voices. This self-talk is activated when we praise our own selves or we are happy with something we have done. For example, I'm proud of something I have done. Management self-talk is relevant to trying to understand how to perform a task in general. And an example of this is, I'm mentally exploring a possible course of action. Next slide, please. Hi, next slide, please. Thank you. So for my thesis, I did 3 types of tests to analyze the data: independent samples t-tests, regression analyses, and a mediation analyses. So the independent samples t-tests found that all factors of self-talk were associated with higher severity of disordered eating, as mentioned in this table here. Based on this, we understood that those who have disordered eating also have higher social assessment self-talk, which can be an explanation for those people who have high disordered eating generally experience high loneliness levels. Therefore, the loneliness level is compensated for by consistently active social self-talk. Reinforcing self-talk was also higher in those with disordered eating, which was a surprising finding because it was hypothesized that only critical self-talk will be higher. And this was explained in terms of the pride people take in the eating disorder. For example, an anorexic person might take pride in the fact that they are able to strictly follow dietary regimes. Or someone who's bulimic may be very happy that they're able to compensate for the binge eating episodes. Critical self-talk was also associated with higher disordered eating, and this was in line with previous studies. And this is based on the understanding that one's eating disorder voice or the self-talk they have in relation to disordered eating is generally very harmful in nature. It is very powerful and very negative in nature. For example, if you don't follow this dietary regime, this will be the result of it. Management self-talk was also again associated with higher severity of disordered eating, and this was as expected because in disordered eating, there's a lot of goal orientation presentation. For example, this is my goal weight, or this is my goal diet, and I'm going to reach this no matter what. Because there are there's an overlap between symptoms of obsessive compulsive disorder and disordered eating. So there's an obsession with attaining the goal no matter what. So this was in line with previous research. Also, significant differences were found in the level of inner voice malevolence and inner voice omnipotence. In both cases, those with higher levels of disordered eating had higher levels of inner voice malevolence and omnipotence. And this was also as expected because as malevolence of inner voice is similar to the concept of criticality of inner voice, this is explained in terms of, again, the eating disorder voice being sort of omnipotent and negative in nature. And the inner voice omnipotence, that is the power of voice, was also as expected. Those who have disordered eating feel in a way subordinate to the eating disorder voice. That is, they feel subordinate to their inner voices which direct them to follow a diet, or which direct them to binge, or which direct them to purge after binging. The regression analyses were conducted between all factors of self-talk and disordered eating. While there were significant results revealed, there were no, as such, significant beta levels. And therefore, it can be understood that while in general all factors of self-talk do predict disordered eating, there is not a single factor of self-talk particularly which is associated individually with the same. Self-talk frequency, which is basically the level of activation of self-talk, was both more active in those with more severe disordered eating as well as predictive of the same. A multiple regression was also conducted between inner voice malevolence and inner voice omnipotence, and there were significant results revealed. However, what's important to note was the malevolence of inner voice did predict disordered eating individually. Therefore, for future research, it would be advised that malevolence of inner voice be studied even further. The mediation analyses found that self-talk frequency predicts disordered eating via inner voice malevolence. That is, the activity of self-talk predicts the severity of disordered eating through the nature of the voice. Therefore, that is, disordered eating is not just related with how active the voice is, rather it is the nature of the voice or which voice is active which predicts disordered eating. Next slide, please. So two very important studies in this area are one by Rachel and his colleagues and one by Scott and colleagues. The first study stated that self-talk frequency is associated with worse mental health and suggested that it is a risk factor for psychological well-being, which was proven in this study as well, as it was found that all factors of self-talk were associated with more severe symptoms of disordered eating. Scott and colleagues' study stated that failure of some health professionals to acknowledge the hold of such procognitions is an important factor in increasing treatment resistance. The meaning of procognitions here is that in disordered eating, the cognitions are often self-fulfilling, which was explained in terms of the self-management dialogues or self-reinforcing dialogues. That is, very often people who present disordered eating behaviors, as I mentioned before, take pride in their disordered eating. For example, an anorexic may feel proud that they're able to follow the dietary regime. Or the bulimic may be proud that they are able to purge and compensate for their binge eating episode. This research study has relevance in the intervention and treatment of disordered eating for those seeking help. Specifically, the results can be used to adapt therapeutic approaches which target voice hearing experiences, such as emotion focused therapy, compassion focused therapy, and client centered therapy, to encompass the difficulty surrounding disordered eating. These efficacious approaches improve the patient's condition by reducing the psychological distress, which by helping them establish control over their voice hearing experiences. Now, in emotion focused therapy, there is this concept of two-chair intervention or split work. In this approach, basically, the client is seated across an empty chair in which they imagine their disordered eating to be seated, and they interact with it. They interact with their disordered eating, and they get to know their disordered eating voices, intentions, their goals, why they're active, etc. Basically, in emotion focused therapy, two-chair intervention or split work is particularly important in targeting self-criticism. This is done through externalization of inner voices and distinguishing primary emotions from secondary ones. That is, one is able to distinguish themselves from the eating disorder voice. They understand that while the eating disorder voice is working from within them or active within them, it can be separated from them. It can be viewed as a separate entity. In compassion focused therapy, voice hearers are taught to notice their threat based motivational systems when they arise, understand their function in the context of their lives, and shift into differential motivational patterns that are oriented around safeness and compassion. So basically, in compassion focused therapy, when one's critical eating disorder voice is activated, they notice that it's activated. They notice that there's a voice inside them which is controlling their disordered eating behavior, which they cannot control themselves. They understand their function in the context of their life. That is, they understand the results of it, they understand the intentions, they understand that it's simply active. And then they shift into differential motivation patterns that are oriented around safeness and compassion. So they basically acknowledge the voice's presence and they shift into another pattern of thinking. That is, they sort of change the narrative of the voice. Client-centered clinicians working with inner voices use reflections to help clients develop meaning bridges between conflicting inner voices present in them. This is done by the clinician reflecting on one voice at a time. This may trigger elaboration in that voice or stimulate an oppositional response from another voice that wasn't reflected. In this way, Clients gain clarity and may learn how to control and facilitate their inner voices. So, client centered clinicians work in a manner similar to emotion focused therapists. However, in emotion focused therapists generally ask the clients to express their varied voices, whereas client centered therapists emphasize or explore voices themselves. In this manner, when one voice is elaborated, the other voice, which did not get attention, is either subsidized or sorry, is either pushed down or just sort of extinct, ex- killed in a way by not being elaborated on, or that voice sort of expresses itself to draw the attention. In this way, the varied voices are activated at once and the intentions are understood. Some possible aspects of eating disorder self-talk that can be addressed in therapy as identified by qualitatively interviewing those with clinical levels of certain eating disorder symptoms includes promises, consolation, self-congratulations, threats, cautions regarding eating, need to purge, need to exercise, self-disappointment, self-abuse, self-punishment, self-criticism, comparisons, reinterpretations, sensory misconceptions, denial, moral judgments, rumination of life, weariness, misery, lost identity, need for secrecy, rebellion, pride in eating disorder, and fear of life without eating disorder. Promises made by eating disorders are basically those which promise the person who's suffering that, okay, if you look a certain way, you will be loved, or that if you're able to engage in this diet, it shows that you are a person who's goal oriented. Consolation would be maybe those with bulimia sort of console themselves by purging. Self congratulations, again, pride in being able to follow the dietary regime. Threats, as said, omnipotent inner voices are very powerful in nature. So the eating disorder voice can be experienced as a threat to oneself. Cautions regarding eating. Those with disordered eating often follow very, very strict dietary regimes. Need to purge. This is a symptom of bulimia, and it is in a way out of the individual's control because, as I said, there's an overlap between symptoms of disordered eating and those of obsessive compulsive disorder. The need to exercise, a symptom of anorexia, again, it's out of the individual's control. While exercising can be viewed as a positive thing, after a point, when it's excessive, it becomes a negative thing. That is what happens in anorexia. Self disappointment. So, in case a dietary regime is not followed, because, for example, they are in a social context or the moment requires them to eat, it becomes a very big disappointment for the person who has engaged in an eating behavior, even though they had promised themselves that they wouldn't. Self abuse. As the voice is active within the person, it can be experienced as the person speaking to themselves rather than a voice which can be separated from themselves. Therefore, it becomes a form of self abuse. Self punishment. Many people exercise excessively as a form of self punishment, or they don't eat for several days at once as a form of self punishment. Self criticism. If I don't exercise regularly, I won't be loved. Or if I eat this, I will not, it will be an indication that I'm not a goal oriented person. Comparisons to others. I should not eat XYZ because this is what will happen, and then I wouldn't be as beautiful as this other person. Reinterpretations may be in the context of social interactions. So, for example, if an individual says, I look nice, it's because my body has changed and it looks like this now. Therefore, they're saying I look nice. It's not because my outfit is nice or I just generally look nice. It's because my body looks like what it does. Sensory misconceptions. Those with eating disorders, it has been noted that they also undergo neurological changes. So their senses or the brain areas that are activated, for example, on eating something sweet. For most people, dopamine is released. However, for those who have eating disorders, it is noted that no rewarding sensation is as such experienced on eating something they like. Therefore, there is as such no sensory feedback to eating anything. So this is the misconception for the same. Denial. People with eating disorders often go into denial about suffering because there is sort of pride in having an eating disorder, especially among those with anorexia nervosa. Moral judgments, the judgment from others, one's own judgment about self, etc. Rumination of life. Those with eating disorders ruminate a lot. It has been noted that they have extreme self-talk frequency, as noted. Also, they are often prone to depression, and with rumination is a sign of weariness. It is noted that they are often tired, not just physically but also psychologically. Misery. After point, initially the eating disorder is experienced as a friend. It has been noted that the voices are initially benign, they are more manageable. However, eventually they become omnipotent, they become powerful. So there's a misery in the eating disorder, lost identity. Those with eating disorders often absolutely lose the identity to just having thoughts about eating and food intake. There's a need for secrecy. Those with eating disorders often experience a lack of understanding about the disorder among people. Therefore, they often decide to hold back on what they're experiencing. Rebellion. Now, a form of rebellion can be, for example, binging even when you would like not to. So there is this sort of ricocheting between extreme poles in disordered eating. There's a pride in the disordered eating, as I mentioned, and fear of life without the eating disorder. Because you have lost your complete identity to the eating disorder, there's a fear of what will life be without it. Next slide, please. Hello. Next slide, please. Thank you. So here are some references I've used in the presentation, and for more information, please do get in touch with me. Thank you.